Well, it's a gift to be here. I mean that sincerely. It is always, I think, heartening for me to be among people in the People's Republic of Oregon or Portland that actually have clarity about principles and values, and it is just a treat. So what I'm going to speak about today is the so-called Affordable Care Act, and I have to give Gail credit for the title here, Living and Dying on Obamacare, which is far more of a catchy title than the so-called Affordable Care Act. Many people, because it has been so closely entwined with the, what now?
My phone. Did I reach there?
Oh, you did actually.
Thank you.
Yes,
Sorry,
all
I
right,
don't
no
want
problem.
this.
Yeah. I don't have to answer her phone now through the phone. That's very good. What a relief. All right, so the act is so intrinsically entwined with the current leadership of the country that it has indeed been dubbed Obamacare, and I think it's far more familiar to people than the so-called Affordable Care Act. And I keep using the word so-called because I'm going to give you updated information, not just from some life interest group, but from the Congressional Budget Office that shows that the closer you look, the less affordable it becomes. This first slide just shows where I live half the time. I was actually down at that building. If you look at the picture on your left, that's by the waterfront, the Center for Health and Healing. I'm a family physician. I practice, I teach residents, I teach medical students, and we're on the 9th floor, at least half of the 9th floor. The other half is cardiology, so if we don't do such a good job in preventive care, they wind up with our colleagues. That building is actually a Platinum LEED award-winning building, and that because it does things like catch the sunlight instead of just regular sunshades. It catches rainwater and recycles it through toilets and all. And that you know, there's a chuckle or two here. You know, we're supposed to be a very progressive state where we recycle everything. And so, you know, you have to come up with some new warnings for people. And for those in the back, it says, toilets and urinals flushed with reclaimed water, do not drink. Now, we have a dog, and maybe it's directed at my dog. I haven't ever brought the dog to the Center for Health and Healing, but it is a little humorous of who are they actually expecting to read this? I don't know, but you have to laugh at yourself. It's over every single toilet in the building. At least it was. I think people have stolen the signs to take them home, so they're not in many of them. So what I want to cover today, to keep myself straight and not go off on too many rabbit trails, I want to give you a little background of where we are, why did we get to talking about these kinds of things. I was the course director for one of the largest courses in the medical school, well, it still is, the Principles of Clinical Medicine, and every year we would have panels of people talking about the problems with healthcare in America and how we're about headed for a cliff and we need to change things. For the entire 15 years I was the course director, so the whole issues that I'm going to wrap up in a slide or two has been discussed at length. I want to talk in all fairness to what are the goals of Obamacare, because some of the goals are actually laudable. They're not something that you should be mad about when you start talking about allowing access to care. That's the same thing that people do when they go on missions to Africa, Ethiopia, wherever else that needs our help, Haiti. But I do want to deal with the cost issues, and I certainly want to deal with ethical issues and some of the trade-offs that we get. And I'm going to touch on the legal uncertainties, and Stephen Ertel did a wonderful job of lining up where we are, and so I'm going to reinforce some of those points and give you a few more specifics, and then hopefully allow enough time for discussions. I haven't put so many slides in here that there will hopefully not be any death by PowerPoint. All right, so the background, this is my one slide capturing the background. If you look at this slide, it's a bar graph, and it shows you percentages on the vertical axis. And most of the healthcare is covered today, or at least it was at the time this slide was made, because there's fewer people employed right now statistically, but 55% at the time this slide was made in 2010 were covered by employee-sponsored insurance. And then if you look at every single bar except for the last bar, those are actually government programs. That's Medicare, Medicaid, other private insurance coverage. This could be TRICARE, that kind of thing. It could be direct military coverage, like my daughter, Susan, who's at Fort Sam Houston, giving service for the tremendous gift she got from the government, the military, and giving her tuition free through the University of Portland to become an RN. So it's quid pro quo, and that's just as it should be. She has 5 years of service obligation. I'm mentioning that specifically because I'm going to hint at what I think is some of the solutions for us that would be, I think, creative. A lot of times when you talk about what are the problems with things, you'll have people saying, oh, that's fine, Dr. Toffler, but what's your solution? Well, the last slide, I'm going to share what my solution is so you can have that in your own mind about how we could get there without 2,700 pages. All right, so there are other problems besides the money, the dropped insurance coverage. But by the way, I just want you to point out, we already have virtually half the health care today in the country being paid for by the government. That was one of the thrust points I want to make there. Well, we do have problems today, dropped insurance company coverage. You change jobs. You can't necessarily take your insurance with you. There are people who are so-called uninsurable. That is that insurance is really, you have to buy before the accident. If you have an accident like they have on those Geico commercials, it's a little bit too late. Some of those commercials, 15 minutes too late, whatever it was. But you have to get it. So it really isn't insurance if you buy it after the fact, but that is a problem for sure. Liability, the direct and indirect costs are incalculable. And so I want to just touch on this because commonly the leadership of the country, that would be the president, had said that liability isn't really on the table. It's only a small part of healthcare costs. You've heard that, right? 1 or 2%. And that is true about the direct costs. But this week I had one of my patients delivered by C-section. She could have tried to have the baby by vaginal birth. She chose to have C-section. Now the C-section rate in the country is over 30% nationally. For medical reasons, it probably could be 15 or 20%, depending on whether the center is high risk or not. A lot of the pressure to have the C-section is driven by legal issues. Because if you're an obstetrician, you're a family physician, you're a nurse midwife, if a person had a mishap and you'd gone to C-section, you did all you could do is the mentality. And by golly, if you sweated bullets for 30 hours and tried to have the baby, and God forbid it's the 1 out of 200 babies that has a problem anyhow, just statistically speaking, it was because you didn't do a C-section. Now, there are millions and millions of dollars that have exchanged hands over that kind of thing. You can't go to the emergency room with a headache where you'd go home and be followed with continuity because the average bill going into the emergency room for an acute issue is in the thousands and thousands of dollars. One of my colleagues went in with dehydration, and with a 6-hour stay, 8-hour stay, she got a few liters of fluid. The bill was $7,000, $8,000. So, now I'm not blaming emergency room doctors either. I'm not dragging on anybody here. I'm just saying this is the state of the art. So the indirect cost is almost incalculable when you think about somebody, you want to make sure they don't have that aneurysm, that 1 in 10,000 person doesn't have a barianeurysm causing their headache. And these are the kinds of things that are driving us to use many more technological interventions than necessarily are ideal from a medically oriented point of view rather than a legally oriented point of view. So what is the goals? Why are we doing this? Well, the soundbite is we want all Americans to have quality, affordable health care. It's kind of like mom and apple pie. Why would you be against that? We want to regulate the marketplace so we don't have people gouging and the like, because you've heard stories of people who fraudulently bill Medicare, whatever else. Extend relief to small businesses because obviously from a leadership point of view, they're saying small businesses are being crushed by the unnecessary burden of healthcare costs. We want Medicare to have affordable prescription drugs. Well, who could be against these things? Prohibit denials of pre-existing conditions, and that sounds fair too. I mean, why should somebody with diabetes not be able to access health care? And you want to limit out-of-pocket costs because you want people to have the crushing weight of medical care keep them from paying their mortgage or keep them from going to the grocery store. Now you have other specific goals that are kind of interesting, like allowing all dependents to stay with their parents' plans until age 26. You all are aware of that. I have 7 children. My wife Marlene and I have 7 children. I'm not sure I want my kids to stay on, in all seriousness. I mean, this is a dependency state, and yet people celebrate this, and what it does do is create that dependency state that you really don't want your children. You want them to spread their wings and fly. So I'm wondering how this gets snuck in there. Expand Medicaid to millions of low-income Americans. Well, right now, virtually every state is reeling from the weight of the unfunded mandate to fund the people that are on Medicaid right now. So expanding it is an interesting concept because they're going broke with the current system. So let's take that current system that's going broke and expand it. You want sliding scale subsidies to make the insurance more affordable. You want insurance companies to be accountable, clamp down on abuses. Who could be against clamping down on abuses? These are seemingly good things. And investing in primary preventive care, I'm all for that. It is mom and apple pie. I'm a family physician. I give a talk every year to the first-year medical students that's on health promotion. It's probably the only formal talk that they get. I mean, they got a lot of informal reference to health promotion and preventive care throughout for 4 years, but it's the only formal talk, I think, in the curriculum when they talk about health promotion. Almost 48% of all of our healthcare maladies are preventable by lifestyle changes and choices. I mean, I could give you slides on obesity that show that, virtually every state has turned yellow and orange and red from having previously been light blue, meaning it was under 10% overweight or obesity, and now we're practically at a 30% level of overweight in all states, with some of the states leading the way, and Oregon's a little better than some, but it's right up there as well. So a lot of it's preventable, and it's not just weight, it's also the amazing drug abuse we have here. If you look at Europe, the rate of drug abuse has doubled in the last 10, 15 years. You say, wow. And it's still 1/10 the level in the United States, 1/10. So you see, what are the costs of drug abuse? Well, it's hepatitis C, it's crime, it's breaking into everything from parking meters to your local bank to feed your habit. It's astonishing how destructive those kinds of things are. And that is what is fundamentally, as I think about the children, 43% of babies now are born to single parents. We know that often that's a struggling, heroic mother trying to cope with what has been an abandonment in her life. As you think about, 80% of the people occupying our prisons are coming from fatherless homes. So if you want to make a dent in healthcare costs, you have to look at the fundamental building blocks of society. You can't just do it from the top down unless you want to break the piggy bank. What are the costs? This is from the Congressional Budget Office, a so-called neutral organization, and I say that because I didn't realize that the head of the CBO is appointed by the president. So, and the other thing they have to do is they have to accept the premises that are given to them when they make these estimates. So if the Congress says we're going to cut $534 billion, $538 from Medicare, an organization that's already going broke, faster than Social Security, we're going to cut that from that. We have to accept that premise. You follow me? That's what the CBO does. So it doesn't include, when they say it's going to save $143 billion over 10 years, it doesn't include the fact that you're going to have a tax increase for 10 years to support just 6 years of actual healthcare changes. It doesn't include the so-called doctor fix. That's where for years, many of you may not know this, but doctors have not been being paid fully for any Medicare patient that they see. So much so that people are now running from taking care, people being physicians, healthcare organizations, from taking care of Medicare. That's people my age in 2 more years and older. Now, why are they running? Well, they're running because they are actually below the profit line if they take more Medicare patients and displacing people who are paid for, say, Blue Cross or Aetna. And so I have many senior patients in my practice. Some of them have been grandfathered in. They don't have to worry about it. Others have tried 10 other offices, have all been rejected, and we still haven't rejected them yet at OHSU. So this problem of the doctor fix is huge, and it's a subject of debate, not just in OHSU, about how do we deal with this, because you become then a missionary structure, not a nonprofit, or you maybe do become a real nonprofit, if you will. And this is reality. Just to illustrate this point, one of my Medicare patients, she's 70 years old. I've taken care of her for years. She is not out in any job. She's totally dependent on Medicare. She had a shoulder injury with a rotator cuff. So I referred her appropriately after the MRI showed the deep cut in one of her rotator tendons to my orthopedic colleagues. She then writes an angry note to me on the MyChart. That's how we have these great communication tools now. And she's upset because the appointment is not, this was 2 months ago by that, this was in February, was not until December of 2013. You can't make this up. It's not Canada. It's not UK. It's not in the future. It's now. So I had to go to bat, as I've had to do now, with 3 people. 2 of them were Medicaid, that is for the uninsured, or the people who are on welfare, or people who are below the federal poverty line, or several times the federal poverty line, wherever they put the cutoff. And I've had to actually call my orthopedic colleague, can you, and with my hat in hand, can you please see this person before 9 months, or in this case, more than 18 months out? So this is a huge issue when you say, this is the way it is now, and your contractors come in late, over budget, your house hasn't had the quality that it wants, and you want him to build more houses for you? I mean, this is the metaphor I would say. So revised gross estimate just came out in March of this year. It's not under $1 trillion, which they struggled with smoke and mirrors to have happen. It's now $1.76 trillion that CBO estimates it'll be in terms of the cost. And it already has caused an increase in costs. They've already gotten rid of the CLASS Act, the so-called of long-term care coverage. It was an acronym to describe covering people in long-term care facilities, which is not part of Medicare. 70% of our senior citizens are taken care of in private homes, just as we were privileged to do with my parents and with Marlene's father before they all passed away in this past decade. Cost issues. Where do you get the revenues of $510 billion because of these increased costs? Well, it's going to come from penalties. If you don't insure, then you're going to get 2.5% of your AGI that if you don't buy the insurance. You're going to have people who want to have full coverage and have the benefits that they've always enjoyed have a premium on that kind of insurance, 40% extra cost for your insurance. There'll be a 10% tax on tanning services. Oddly enough, why they pick on tanning services, I'm not sure. It's a pretty good way to get your vitamin D level up. I mean, it's not that bad. You eliminate the deduction for employer Medicare prescription coverage. In fact, right now, the health savings account in the next line, it severely limits your health savings account. This hurts me already because I would buy, with my wife having an illness, having a cancer, unfortunately, we have to struggle with that. Our health costs last year were $14,000 out of pocket. So I would have liked to have purchased $10,000 of HSA coverage, so it'd be pre-tax dollars. I'm limited by President Obama to $2,500. That is a new thing it's ratcheted down your benefits already. Your taxes are going up already. Again, this is in that period before Obamacare comes to pass. These aren't theoretical. You used to be able to take over-the-counter prescriptions and actually use them in your health savings account. That no longer is the case unless you get your doctor. Thinking about driving up costs, you have to go to your doctor, have to pay him or her, and then you get your little prescription and you're able to write it off on your health savings account. These are the little things that already have happened, and they're not so little when you have a serious illness. And now, of course, we're going to have excise tax on healthcare businesses, pharma, devices. So those life-saving devices, the implantable defibrillators, all these kinds of things that we save people's lives on, those things are going to now be taxed and cost more. If you don't improve the efficiencies, so the CBO says, well, what's going to happen? Well, they admit that it's going to have to affect either your access, just like it does with the health plan in Oregon, Oregon Health Plan. They sometimes have lotteries to see if you can actually get in. They sometimes change the line of cutoff of what's covered, what's not covered. And these are the ways that you do this. You don't improve quality. You actually have to lower quality or decrease access if indeed you don't come up with some mystical fraudulent cessation that has been talked about. And it isn't clear in that budgetary reality what Congress would do. Would they increase spending? Would they increase revenue, increase debt? As I think about it, would they just print more paper money? I don't know. But somehow you've got to make the budget balanced if you don't want to be Greece. So they want states to increase the Medicaid eligibility. That's the program for the people who are in the poverty level, or 133% of the poverty level. And all non-elderly people who have less than 133% of the federal poverty level. The elderly people getting to be my age or older would be on Medicare. And these expanded costs would be, there'd be 35 to 40 million new people on the state rolls over the next 10 years. No one has said, where does the state get the money to do this? It was just mandated among the 2,700 pages. You've got to increase custodial care costs for the disabled, and you're certainly going to have an adverse effect on current recipients because you have to do one of those two things. You either have to decrease access or decrease quality. Now, you can learn from what's already gone on. Now, I want to also articulate what I've read Romney says about it, because often people say, well, Obamacare is just Romney care. Well, there's a huge difference. In the state of Massachusetts, one of the most liberal blue states on the planet, and also one of the wealthiest, the people actually like Romney care, if you go and do a poll right now. They also pay the highest insurance premiums of any families in the United States right now. Their insurance costs have gone up, and it occupies now 40% of the state budget. Their insurance premiums for individual families are the highest in the nation. You didn't hear this when you heard about all these other states having insurance rates go up. Well, they went up in Massachusetts too, because they hadn't fundamentally changed the system. They just passed an insurance law. They didn't change anything about, were there more primary care doctors to actually take care of these people? No, everybody had a card, but then you still had to go to the emergency room. You know, this was your level of health care when you don't change the fundamentals. Now, Romney also said it's okay if a state wants to do what Massachusetts, that's okay. On the other hand, I'm not sure Massachusetts' plan will work as well in Alabama or necessarily even in Oregon. And that's the point. Just like with Roe versus Wade, when you impose things from Washington, then you basically, you don't have great solutions. You don't have it being decided by the people and for the people, and you can't adjust it very easily either, as we found out with Roe versus Wade. They've had 18,000 or more jobs lost, and the individual coverage has obviously increased since the passage of Romney Care. Although, what does that coverage mean? Like I say, it means now you have a little card that pays for your emergency room visit. Now, there are ethical issues, and these are critical, and particularly as a minority myself among my liberal colleagues at the university, I've had real lived experiences with these kinds of things, because in 1993, I think, I stopped contracepting for non-medical purposes, that is for birth control, because I saw the harm that this was doing to women. Just like one of the female doctors just wrote in response to the national issues about how Nancy Pelosi and others in Congress are really out to lunch. One of the colleagues in the House of Representatives actually had the audacity to call her female colleagues that disagreed with her, that contraception wasn't a sacrament and contraception wasn't necessarily the gift to women that President Obama and Kathleen Sebelius thinks it is. And so she called those colleagues in the House of Representatives, women are men with breasts. Men with breasts was the title. And that triggered the absolutely, I think, you can do a Google search on men with breasts and read the response of a female physician who understands what many of you know and what I know, which is that women ought to be told the risk benefits. And if you were told the risk benefits of these so-called contraceptives, these so-called birth control pills, these supraphysiologic doses of anabolic steroids that have incredible consequences on the human female, that you might make different choices. Not everybody, but you might make different choices. If you knew, I'll give you just one little pearl. Like in 2009, the Hutchinson Cancer Center said that if you're triple negative with your breasts, and you don't know that until after you already have cancer, but that's almost 1 out of 5, 17% of women. If you're triple negative, you take birth control pills for even 1 year prior to 21 or 5 years after 21, you have doubled to quadrupled your lifetime risk of breast cancer. Now, would that make you change your mind about trying to treat your acne with supraphysiologic doses of anabolic female steroids? It might. Let's see. Acne, breast cancer. Acne, breast cancer. I don't know. And we have unbelievable. On the 16th floor of that Platinum Ward building, we have dermatologists who are salivating for patients because when the economy goes south, you know, one of the first things off of your first do list is, I got to go get my acne treated. So, you know, I'm not making fun of derm. I'm just simply saying, look, we do need to talk about these things and people ought to be informed. You know, if you ever listen to the litany of problems that come when you take birth control pills, when you look at Yaz or look at these things on TV, and at the end, what does it say? These pills might cause strokes, heart attacks, clots in your legs, pulmonary emboli. You better check with your doctor. But we'll make them over the counter. No. All right, so what are the religious freedom issues? I mean, that's been articulated already in a couple different sessions here. The reality, of course, is that people of faith, people with integrity, are being asked to figure out in the next year how to park your integrity by the door and go along with this, to do things or refer for things that you find violate your own integrity, your principles, your faith. Unless you have employees that are all of your faith persuasion, Baptist, Catholic, whatever it is, but if you actually take care of people who aren't Catholic or Baptist or Muslim, whatever else that you might have a problem with, then you have to comply with this and you'd have to provide these coverages. Mandated pulse. I'm a co-author on an article we're working on this physician order for life-sustaining treatment. Think of that. It's a physician order, not a patient-directed thing. In fact, many states, you don't even have the patient sign it. So these are very dangerous things in a state like Oregon that was the one that inaugurated assisted suicide, Washington State to the north. Who decides that your life is no longer worthwhile? Who decides that things are futile or not? I mean, think of the power that we're giving to some people. Differential treatment by age. What were the things that were said recently when the former Vice President Cheney received a transplant? What kind of things were people saying? Let him die. He's too old. He never had a heart. Why give him one now? I mean, you can't make this up. The vitriol, the lack of compassion by the so-called compassionate party is just breathtaking. So you all know the story, I mean, of how you allocate resources when you don't have them scarce. This is actually here in Oregon. This is Barbara Wagner. She's a 64-year-old retired school bus driver who had recurrent cancer, lung cancer, metastatic cancer, not too different, although it's a different source than my wife's has. She was in 2 years of remission. It came back. Her oncologist in Eugene said, you know, we ought to try you on Tarceva. It's a targeted chemotherapy that gives you a 45% increased chance of being alive in 1 year if you take it. She said, I'll take it. Much like my wife and I are taking every option we can to be grateful for every day that we have. Well, the Oregon Health Plan said, well, that's not covered because it's $4,000 a month, and you statistically have less than a 5% chance of being alive in 5 years, so you're below the line. So in the letter that denied her care for Tarceva by Genentech, a targeted chemotherapy drug, that doesn't make your life miserable. It does go after the cells and gave you a 45% chance of being alive in 1 year, more than not taking the drug. It's denied, but we will pay for palliative care, including 100% for assisted suicide. Now, it's just chilling that rather than being apologetic for this crass, cold letter, the defenders range from the very people who set the policy in place. Well, we have to do that. That's what the panel here in Oregon decided. That was the line. And it's from people, civilians, as well as doctors and nurses and politicians and like. So we're just telling them what the circumstances are. Barbara's response was, who are these people that tell me that my life's not worthwhile or I can't do this? Fortunately, the evil pharma company, Genentech, said, we'll provide the drug to you for free. And if you're doing well in a year, we'll give you some more, That's what they said. So, we often demonize these large corporations, and yet we elevate the politicians. So the real question is, who decides? Who makes choices like that? Is it the people? Well, sometimes it is. We are the ones that voted assisted suicide at the ballot box, and if you're people voting for things and you're not voting based on principles, you're essentially a mob. It's chaos. It's like a lynch mob around the tree. Hang them, So people can be dangerous too. Is it the president? Well, we can have presidents like George Bush, and we can have presidents like President Obama and everything in between, and you're going to get very, very different decisions based on who happens to occupy that office. Is it the Congress? Well, is it Nancy Pelosi, or is it Harry Reid? Is it John Boehner? I mean, who decides? Or is it the Secretary of Health and Human Services? If you go through the 2,700 pages, the name of the secretary or the Secretary of Health and Human Services comes up more times than I could count. I went through several hundred pages of the 2,700 pages. I lost track after about 200, 300 times I came across the secretary shall decide. It's breathtaking, the power that's been installed. So here, I want to give you a little diagram. You can see this from the back, I think, very well. This is Obamacare on one slide. But notice what's in the center is the Secretary of Health and Human Services. She decides, Kathleen Sebelius, the former governor of Kansas, who was in sync with George Tiller, God rest his soul. I mean, this is the woman who defended the undefensible, the late-term abortion specialist, and protecting him in the state of Kansas. And she was tapped to head this agency, which fits just in sync perfectly with what Stephen Ertel said in terms of where the heart and soul of our current leadership is. So the results thus far, instead of reducing the deficit, when Senator Johnson queried Kathleen Sebelius, the same person who's in the center of that slide, instead of saving $143 billion, we're adding $54 billion to our deficit, correct? That is the current data. And he was asking these questions on March 6th, a little over a month ago. The health costs are actually rising since the passage of this bill. The average cost of a family health care plan now is up $2,200. It was supposed to drop $2,500. That makes an actual difference between what was projected and what happened of $4,700. And right now, based on a survey by the Kaiser Foundation, or the McKinley Quarterly, actually, in June of last year, employers plan to drop coverage. I know I talked to some executives, people in the Legatus Society. These are people who manage a lot of people, and they say, well, we'd have to be economic fools not to drop the coverage, because just let the government pay for it is a lot cheaper. Of course, the problem with that strategy is you've just empowered the government to make all of your decisions, and I'm not reassured by some of the decisions they've made, particularly in the last several months, in violation of the promises that they made. I mean, think of the promise that the president made to Bart Stupak of Michigan with the executive order. And what are we all talking about right now that's laced throughout the health care bill? But they reassured us nothing in this bill says they're going to provide for abortions. That's what Nancy Pelosi said. So waivers, because of this is so onerous, there have been over 1,200 waivers granted by who? The secretary. Who did she grant them to? Primarily to labor unions. 543,000 employees from labor unions have been granted, or the companies have been granted waivers to not have to go under these laws or principles, guidelines that have been passed by Obamacare. On the other hand, less than 70,000 employees are representing firms that are private firms. So you see the bias in who decides by Ms. Sebelius. And they're essentially seeking a temporary shield from the onerous economic burden of the early provisions of Obamacare, not even getting into the full. And this, again, was very authoritative, the Center for Consumer Information and Insurance Oversight. So what are the trade-offs we've got? If you look at this little graph, choices under the current system, if you stayed and didn't do anything, would be the same. If you look at the Affordable Care Act, the Obamacare, your choices are definitely going to get limited, despite of the president saying, if you've got your care, you can keep it. Well, all those things have already passed where things haven't been kept. The number covered would obviously go up if you say you're mandating by federal law that you have to cover people, you're going to have more people covered. The access would, I put plus minus there because just as I said in Massachusetts, yeah, you have the right to get care, but just like my patients who are on Medicare right now are having a hard time accessing care and it hadn't even been implemented fully, this is going to get worse. So I say, yeah, you're going to have coverage, you're going to have your card, but you then have to find the facility that actually provide the care, because nothing in the law has changed the dynamics of how many doctors we have, how many primary care doctors, how many specialty doctors. And obviously the government involvement, as you saw from that last slide, is going to go hugely above where it is now, even though it's pretty high right now. So there are legal uncertainties. There are already 27 states that are suing the federal government. The federal mandate versus the states' rights. Are these provisions, are these increased costs, are they a tax? Does it really fit under the Interstate Commerce Clause? The federal courts, before it got to the Supreme Court, were split. The Supreme Court arguments were heard last month, unprecedented, or not, I shouldn't say unprecedented, unusual, where they actually had 3 days of arguments because this issue is so central to how we live as Americans. And we should, as was said, have a decision in late June. The issue on religious freedom, there are organizations like the Population Research Institute, that is often many people in it are Catholic, but it's not exclusively that. That group has already gone on record say, we would go to jail before we would adhere to these laws. These are unjust laws. These are laws that violate natural law. And it certainly violates the First Amendment and the religious freedom that was a bulwark of what's made our country great. So the 3 days were devoted. The first day was to, is this really premature that we're talking about this, because actually it hasn't been implemented. And they pretty well came down to, well, it's not premature, we are talking about it. And the second day they talked about whether the mandate's constitutional or not. And then the third day was this legal concept of severability. If the mandate doesn't stand, can you look at other parts separately? And we had a lot of different takeaway points that I'd give you from those 3 days. This saves you 3 days of watching the cable channels. No, the court didn't wait, as I said. The government really did bore the brunt of the oral arguments in trying to say, even Kennedy, who's this swing vote, as was said earlier, said, this is kind of a heavy burden that you have to say that this is something the federal government should be making people buy things. Why can't they just make them buy cell phones? After all, you might have to use your cell phone to call 911 in an emergency, and what if the government thinks it's a good idea that everybody has to buy a cell phone? And the guy said, well, that's different. That's really different. And every argument he made, Kennedy finally came back and said, everything you've said just makes this perfectly similar. Why can't it do it if it decides that it's important? So the swing vote, Justice Kennedy, is clearly the issue. Another wild card, of course, is Chief Justice John Roberts is a very clear thinker, the leader of the court. And I think he's going to come down because he's also, well, actually, Scalia, I should say, is a very solid vote, I think. He said, you want us to try to, on the third day of arguments, you want us to try to decide which parts of this 2,700 page are worth keeping? What happened to the Eighth Amendment? And the Eighth Amendment, for the non-legal scholars in here, is cruel and unusual punishments, and we can't have it. And, of course, that was a legal crowd. He didn't have to explain himself. It's all about the mandate. So I've shared these things, and I said I'm going to give a little hope. There really is a solution. This isn't like you can't fix this thing. This is Toffler's 5-point health care plan. And the first one is that you have, just like my daughter Susan does, you have a service payback. Right now we have billions with a B, that funded my residency education, and every resident in the United States, after they finish medical school, gets their money as a pass-through from Medicare, the federal government, already. Now, my daughter appropriately has to have some service payback for that great gift. Now, you could offer people, you could pay for your own residency education, but if you accept the support of all of our tax dollars, why don't you have a year or two of payback? You could serve an underserved, like the Southwest Community Center, where my department volunteers on Tuesday and Thursday afternoons. You could do it at the Multnomah County Clinic system. You could go to Indian Hill Reservation. You would have, no matter what specialty you go into, you've got 1, 2, whatever you need to fill the gap. What would the cost of this be? 0. You just transfer responsibility that people who benefit, myself included, from the largest of the people, like my daughter Susan did when she got the highest tuition I've had to pay yet, or had to pay for the first semester before the ROTC picked it up, that you have a little bit of payback. Who would be against that in the room here? Okay, point 2. I didn't see any hands for the purpose of the camera. Primary care incentives, individual and institutional. Well, right now there's some institutions like mine that like to pride themselves on producing primary care doctors, particularly family physicians. We often are among the leading, if not the lead, department in producing primary care doctors. I think we just won an award for having an average of 18% go into primary care. That's less than 1 out of 5, and that's an award-winning performance to show you how weak it is. Now you can imagine there's certain schools, I won't mention names, that don't have that focus. They are much more research-oriented. They're not as interested in producing for the people and what the people's needs are. And that's okay because this is America. But if you do, and you get an NIH grant, which these firms, these universities are very good at getting, then they might have a 5% withhold. And that 5% would go to schools like OHSU that cares about the people of Oregon, at least in terms of trying to produce primary care doctors in addition to cardiologists and dermatologists and left eyeball specialists and these kind of things. Both are good. I'm not disparaging. I depend on my colleagues. It's wonderful that we have the best healthcare in the world, and a lot of it's specially driven, but there has to be a balance. You follow me? So you take that 5% withhold. Again, it's a zero-sum game. Cost is 0. Everybody should have a medical home. I think part of the way I'm able to take care of patients sometimes with half the cost of people who have a more narrow focus is because I get to see them over time. If they have a headache, I can talk about their family life. I get paid for that. It's a good interchange. I get to know them, their family, and I can actually take high quality care, and it costs less. Now, how do you do that? You have to actually incentivize people to use medical homes, and you have to actually produce people that actually would populate these. That is, you'd have to incentivize doctors, and maybe over 4 years, maybe over 10 years. I don't really care that you have a target at some point that there's parity between people who are in primary care and people who do cardiothoracic surgery. I relish the fact we got cardiothoracic surgeons. That's how we made the diagnosis of metastatic cancer in my wife. But you've got to make sure medical students are just equally drawn to different fields in medicine so you have balance. You follow me? What's the cost of such a thing? Zero. You just simply shift dollars. You increase the use of medical technicians. I've told my son, my youngest son, that he's very good with hand-eye coordination because he does video games. Well, you could train my son in about a week of how to manipulate a colonoscope. In 6 weeks, you could train him to pass it through a living person's anatomy. In 6 months, you could train him to identify landmarks for someone like a GI doctor or a surgeon to go and snip the polyps. In 2 years, you could train him to do the snipping of the polyps. And because he'd be focused on the one thing, he'd be very, very good at it. As good as the fellow who came through 4 years of college, 4 years of medical school, 3 years of residency, at least 2 years of fellowship. So 13 years, if I did my math right, versus 2 years. You could pay my son $50 an hour, which is about 4 times more than he's ever earned in his life. He could make $90,000 a year doing 8 colonoscopies a day, 1 per hour. You could pay the MA the same salary. You could pay for the light heats and all that for $50 easily, and you could pay for depreciation on a scope with another $50. It'd be $200 versus how many here have had a colonoscopy? How much did it? Thousands. It's anywhere from $1,200 to $3,000. Now, anyone I say that to is, yeah, they're nodding their heads, except for the gastroenterologists. So, the point is that we're allowing people who have a stake in the game to paralyze us from doing what is cost effective. And last, despite President Obama's rhetoric that, oh, I'm not going to talk about malpractice, everything, not just doctors, McDonald's would benefit by not having unlimited pain and suffering. So you've got to address malpractice like the state of Texas has, like the state of California, and it's caused an influx of physicians in the state of Texas. It's caused a leveling out of the increased cost of at least the direct cost. And I think ultimately, if you had reasonable ways to settle differences among people over the care they received, like they do in some states where they have hearings and boards and ways that avoid the courtroom drama, that you could drive down the decision-making to being more life-giving as well. So that's my overview. We're at the question, or about, I've got 5 more minutes. Questions? Yes?
Would you consider running for president?
I think I've made a couple remarks today and other days that might come back to haunt me. So thank you for your question. Yeah, right. Yeah, Father.
If Obamacare.
So the first question, I guess, was should I run for president? And the second question was, will doctors at OHSU, if Obamacare stands, be then working for McDonald's? I think it'll change the way that we do business. It will definitely, in my mind, have more liabilities than benefits. I'm going to continue to be a doctor. I like the Population Research Institute. If people pass regulations that I have to do things that are immoral, that violate my conscience as a Christian, as a Catholic, I'll go to jail. I said that 15 years ago, and I think that we have to do that. I think that one of the most hopeful things, I think, Father, and we should be proud of our religious, is unprecedented in my lifetime to have the United States Catholic Conference of Bishops stand shoulder to shoulder, using true ethical, moral reasoning, and call the President of the United States on his smoke and mirrors, and that courage is what's going to prevail. It's going to be the courage of the Supreme Court to realize, even if they're convicted that some of the aspects of Obamacare are good, like Kagan is, that maybe a kernel of conscience will come and prick her mind. It's going to be us being willing to sacrifice openly and stand up for what's right, that this country was found for freedom of religious expression. And if we forget that, I think we're lost. And so I think this healthcare is the current battleground. I can see it can go into lots of areas, as Reggie pointed out, with population and the like. And we have to educate one another. The older I get, the more I see these things linked inextricably. And so, I was on a radio program several weeks ago. It was on population. It was kind of a delight to talk about one of the other consequences of this mentality of the culture of death of I decide, I'm the one that's in control, and where that leads. And I remember writing about that when assisted suicide passed. If you allow life issues to be decided by the state, it doesn't take very long, like you get to the one-child policy where the state decides how many people you can have in your womb. I mean, it's breathtaking when you think about, keep your hands off my ovaries and my body and all that, and the absolute deafening silence about the atrocities that the plenary session discussed this morning. Yeah. Yes, Linda. Well, yeah, Linda's point is that there are these coordinated care organizations, so-called CCOs, and it's been a response to the actual declining payments in the system, as well as to the efforts to try to be ahead of the curve with the coming so-called Obamacare. Well, a lot of the state changes are dependent on the largest, $5 billion specifically, that Kitzhaber and others are hoping are going to come their way, because without that, expanding and doing all these government plans is impossible. Where does the government get the $5 billion? Well, it prints more money so far. It's this, it's unbelievable, the euphemisms they use for these things of printing money. It used to be a gold standard. We're essentially, if you don't stop that behavior, you essentially become grease. So the coordinated care organizations are a response to not having enough reimbursement. And, my chair talked about this just a few weeks ago in my Department of Family Medicine, and we don't have any primary care representatives on these coordinated care. And what they're really trying to do is how do we make sure that the trough doesn't empty? And it's not really working at a fundamental change. None of the things I talked about in my last slide is even on the radar. They've been explicitly taken off. So the coordinated care organizations, I think, were not going to be long-lived. They're a temporary stopgap of how do you deal with the current exigencies. Yeah.
Everything is out, right?
Yeah, so the question or the comment is, a very good comment, is that, it's very difficult to sue the government. You're talking about huge, deep pockets of people who are just in business to protect. And, the intimidation factor is huge. I mean, this is the whole point of the government going after, with the FACE laws, not protesters, they're just people trying to pass out information. I thought that was about American. I thought that's what Occupy Wall Street was about, for heaven's sakes. I mean, it's breathtaking, the hypocrisy of the current leadership. And last thing I would want, I mean, as much as I don't like the whole concept of malpractice as a solution to our differences, it would be bad if we got rid of it and let the government decide and essentially became China, where there is no recourse to an out-of-control government. And that was the prescient wisdom of our forefathers, of having a checks and balances, for heaven's sakes. They understood the point you're making. You can't take away the rights of people. That our rights don't come from the king. They come from God. Yeah.
I'm sorry.
I'm out of time. All right. Thank you all. I appreciate it.